we'll be talking about tumors of hypopharynx and pharyngeal pouch. Firstly, a brief recapitulation of what hypopharynx is. In yesterday's lecture also I told you about nasopharynx, oropharynx and hypopharynx. Okay, so this is the cut section of the pharyngeal area. Okay, from posterior part has been cut, and so you can see the inner aspects. So nasopharynx, you can see the nasal septum, and then the turbinates, okay, up till the soft palate. From there up till the upper part of epiglottis is oropharynx, and hypopharynx is below that. Below that is hypopharynx, and below the hypopharynx is esophagus. So whenever somebody asks you about hypopharynx, you need to know that it has got three main regions. Okay, the first one is piriform sinus. All three regions start with letter P. So easy to remember: piriform sinus, postcricoid region, and posterior pharyngeal wall. So on the left side of your screen, you can see an image there. That is an image of nasopharyngeal laryngoscopy or fiber optic laryngoscopy. So the arrow, those arrows, they represent the area of hypopharynx. So in that you can appreciate the epiglottis on the lower side, arytenoids, epiglottic fold, true cords, okay? And then on either side of the arytenoids, there is a recess or a region. That region is hypopharynx. The tumors of hypopharynx again divided as benign and malignant. Benign ones are papillomas, adenoma, lipoma, fibroma, and leiomyoma, whereas malignant one is carcinoma. So the TNM staging, it is similar to the one that we discussed yesterday, right? So the TNM staging, it involves the subsite and size. Okay, so T1 is tumor limited to one subsite of hypopharynx, either posterior pharyngeal wall, piriform sinus, or postcricoid region, and 2 centimeter or less in greatest dimension. Okay. T2 is when the tumor invades more than one subsite of hypopharynx or an adjacent site, or if it measures more than 2 centimeter, 2 to 4 centimeter in greatest dimension without fixation of hemilarynx. T3, if it is more than 4 centimeter, or if the hemilarynx is fixed. That means if half of the larynx, half of the part is fixed and one side of vocal cord is not moving. Okay, T4 is divided as 4A and 4B. In 4A, it invades any of the following: thyroid or cricoid cartilage, hyoid bone, thyroid gland, esophagus, central compartment soft tissue. Okay. T4B is when the tumor invades the prevertebral fascia, encases the carotid artery, or invades the mediastinal structures. So this is T1, T2, T3, T4. For nodes NX, if nodes cannot be assessed, N0 if no regional metastasis, N1, N2, and N3. Okay. In N1, metastasis in a single ipsilateral lymph node, 3 centimeter or less in greatest dimension. N2 is divided as 2A, 2B, and 2C. In 2A, Single ipsilateral lymph node, more than 3 cm but less than 6 cm. In 2B, multiple ipsilateral lymph nodes, none more than 6 cm. In 2C, contralateral or bilateral lymph node involvement, none more than 6 cm. And in N3, metastasis in a lymph node which is more than 6 cm in greatest dimension. Now coming to the one of the important subsites, pyriform sinus, carcinoma of pyriform sinus. It comprises 60% of all hypopharyngeal cancers, involves patients more than 40 years of age, exophytic, ulcerative, or deeply infiltrative. Local spread can occur superiorly to vallecula and base of tongue, inferiorly to the post-cricoid region, medially to aryepiglottic fold ventricles, anteriorly to thyroid cartilage, gland, soft tissue of neck. Lymphatic spread occurs early because of the rich lymphatic network. In 75% of patients, cervical nodal metastasis is first seen as the presenting complaint. So the most commonly involved lymph nodes are level 2 and level 3. Distant metastasis occurs in lungs, livers, and bones. Clinical features, early symptoms are non-specific. They will feel like something is sticking in the throat and pricking sensation on swallowing. There will be referred otalgia, pain on swallowing, increasing dysphagia, sometimes neck mass as shown in the picture could be the first sign, and when it involves the larynx, there will be hoarseness, laryngeal edema, and laryngeal edema. Diagnosis is by indirect laryngoscopic examination. That will tell you about the growth and extent of the disease. And you will also see pooling of secretions because the secretions will not be able to pass down. Nasopharyngeal laryngoscopy, which is a form of endoscopic examination, barium swallow, and CT scan. Treatment depends upon the stage and nodal metastasis. If there is early growth with no nodes, then radiotherapy should suffice. If the growth is limited to pyriform sinus only, then we need to perform total laryngectomy and partial pharyngectomy. If the growth extends to the post-cricoid region, then total laryngectomy, pharyngectomy plus neck dissection. And in all of the cases, we need to give post-operative radiotherapy. So are you guys following?
Yes, sir. Yes, sir.
Okay. So the next is carcinoma of post-cricoid region. Less common than pyriform sinus, 30% of all malignancies. And it is also associated with Plummer-Vinson syndrome or Patterson-Brown-Kelly syndrome. And usually the growth is ulcerative. Spread locally, if it spreads in an annular fashion, it causes dysphagia. It can also spread to cervical esophagus, arytenoids, or recurrent laryngeal nerve. Lymphatics, it involves paratracheal lymph nodes, and most of the times it could be bilateral. Clinical features, females are affected more than males. There will be progressive dysphagia, because obviously there is a growth and the patient won't be able to swallow comfortably. And because of that, there will be malnutrition and weight loss. And if it pushes the larynx or if it involves the larynx, then there could be voice change, and sometimes there can be aphonia as well. Diagnosis. For post-cricoid cancer, you need to perform something known as laryngeal crepitus. Okay, so what you do is you hold the patient's head, and with your left hand, if you are a right-handed surgeon, and then with the thumb and index finger of right hand, you grab the laryngeal framework, okay, and then you try to push it laterally, move it laterally. Okay, so usually there is laryngeal crepitus present, but if there is a growth or a mass in the post-cricoid region, that laryngeal crepitus will be absent because that growth will hinder the posterior part of hypopharynx from rubbing against the vertebra, and hence there will be no laryngeal crepitus. Indirect laryngoscopy, when you perform, there will be edema and erythema of post-cricoid region and pooling of secretion in the hypopharynx. X-ray soft tissue neck lateral view. This is an X-ray which you also get for your university exams. So in lateral view, you will see an increased prevertebral shadow. So one of the differential diagnoses for increased prevertebral shadow is post-cricoid carcinoma. Then you also perform a barium swallow that will show narrowing or constriction. Endoscopic nasopharyngeal laryngoscopy and to find out the spread, you need to perform CT scan of neck and MRI. Post-cricoid carcinoma treatment-wise has got a poor prognosis. So most of the times you give radiotherapy. Sometimes if the tumor is small, then you can also perform surgery, laryngopharyngoesophagectomy with stomach pull-up or colon transposition. Now, carcinoma of posterior pharyngeal wall. So the three subsites, we are dealing with the carcinomas one by one. First was pyriform sinus, second was post-cricoid region, and third is posterior pharyngeal wall. It is the least common of the three, occurs in around 10%. It is more common in males above the age of 50. And there is exophytic or ulcerative growth. Spread. If it spreads locally, then it will invade the prevertebral fascia, muscles, and vertebra. And lymphatic spread can occur bilaterally, and mostly it involves the retropharyngeal nodes. Clinical features is dysphagia or spitting of blood and palpable neck nodes. Diagnosis, again, X-ray soft tissue neck lateral view, indirect laryngoscopic examination with IL mirror and nasopharyngeal laryngoscopy. But you need to take a biopsy and confirm it histopathologically. Treatment again is radiotherapy. If the lesions are small, surgery via lateral pharyngotomy, and if the lesion is big, then laryngopharyngectomy with neck dissection. So for your level, you do not need the details of treatment. If you can just say what are the modalities, that should be more than enough. So radiotherapy, if it is small, lateral pharyngotomy. If it is huge or large, then laryngopharyngectomy with neck dissection. So that was tumors of the hypopharynx. Okay. So another very important topic for your university exams. It is this topic is very important. Okay, pharyngeal pouch. So on your computer screens, if you can see the picture on the top right, then you can see that there are two types of muscle fibers. Okay, the upper one is thyropharyngeus, and the lower one is cricopharyngeus. So below that are these circular and longitudinal fibers of esophagus. So between the thyropharyngeus and cricopharyngeus, there is an area which is a bit weak. Okay, this area is known as Killian's dehiscence, and the pharyngeal mucosa herniates from this area, leading to a pharyngeal pouch, also known as hypopharyngeal diverticulum or a Jenker's diverticulum. You need to know the other names as well. So this diverticulum is basically a pulsant diverticulum. The pharyngeal mucosa herniates through Killian's dehiscence. Whenever the patient is eating or whenever the pressure increases in the pharyngeal mucosal region, this mucosa herniates and forms a Jenker's diverticulum. Both these thyropharyngeus and cricopharyngeus, they are part of the inferior constrictor muscles, and this area is weak, so from there the mucosa herniates. Etiology is not known, but it has been postulated that the spasm of cricopharyngeal sphincter causes this pulsant diverticulum. Also, incoordinated contraction during deglutition. So when you swallow, there has to be a coordinated action of different layers of muscles. If that coordination is disrupted, then that could cause diverticulum. Usually occurs in males more than 60 years of age. Pathology, the herniation of pouch starts firstly in the midline, then goes behind the esophagus and then comes to the left. So in the picture also you can see that this is from the behind, this is from behind. So you can see that the pouch is coming to the left of midline, okay? And the mouth of sac is wider than opening of the esophagus. So if you see the picture, top right picture, then the anterior part, that is the esophagus, the one in the upper part, and the posterior, the lower one, what you are seeing is the mouth of the sac, okay, which is wider than the esophagus. Clinical features, difficulty in swallowing, also known as dysphagia, because after first few swallows, the food will, because the opening of this Jenker's diverticulum is larger than esophagus, the food first goes there, the pouch gets filled, and then it presses the esophagus. So there is dysphagia. Very characteristic of this Jenker's diverticulum is a gurgling sound during swallowing. Okay. Regurgitation of undigested food at night during recumbent position, which causes cough and aspiration pneumonia. Because of collection of food in the pouch, there will be halitosis. Patient will have malnourishment, and sometimes it is associated with hiatus hernia and rarely with carcinoma. So diagnosis is often made by barium swallow. So on your right side you can see a radiographic image following barium swallow, and you can see that the lining of esophagus is narrowed and there is another diverticulum or outpouching seen at the region of around first, second, third, fourth, fifth, sixth, seventh cervical vertebra. So that is Jenkins diverticulum. So treatment, excision of pouch and cricopharyngeal myotomy. There is a procedure known as Dolman's procedure, which is endoscopic division of partition wall with diathermy. And these days, endoscopic laser treatment is also used, which is similar to Dolman's procedure. It uses carbon dioxide laser, and it is done using an operating microscope. That's all. So I would suggest that all of you go back and read about pharyngeal pouch. Okay, it will be asked in one form or the other. It might be a part of your MCQs, it might be a part of your SAQs, or it might be a part of your problem-based question. If not, then it might also be asked in your Viva and all. This is very important. And also read about the hypopharyngeal tumors and cancers, mainly the cancer of piriform sinus, which is the most common, followed by postcricoid region and posterior pharyngeal wall. 60%, 30%, and 10%. Okay. So briefly go back and recapitulate the anatomy of hypopharynx. Where does it start? Where does it end? And what are the important subsites? Subsites are important and easy to remember. All of them start with letter P. So one is piriform sinus, posterior pharyngeal wall, and postcricoid region. Okay. So that's all for today's lecture class. And so we have 83 attendees. So I'll just download your attendance sheet and then we're done. Just 1 second, I'll check the attendance list, whether it is downloaded or not, and then we're done.